Hello everybody, I am Dr. Mohan Natarajan and today I will be talking to you about standards for TB care in India. Now the reason for developing these standards was the perception that people suffering from TB should receive the highest standard of care and support. To achieve this, we needed an evidence based set of standards which was appropriate for our country, and this finally resulted in a document whose prime purpose is to serve as a benchmark which should be observed by all care providers of tuberculosis in India. Now several groups had contributed to the development of this document. This included the Central TB Division, the Government of India, WHO Country Office for India, with contributions from national TB institutes as well as TB experts and program managers. Now international standards were taken into consideration in formulating these standards, and a set of 26 standards were developed which were released in 2014. We have a list of 26 standards, as I mentioned before, of which the first 11 standards deal with diagnosis and treatment. The first standard deals with the testing and screening for pulmonary tuberculosis. The testing for pulmonary tuberculosis is done in any person with symptoms and signs suggestive of tuberculosis, including cough greater than 2 weeks, fever greater than 2 weeks, significant weight loss, hemoptysis, or any abnormality being shown in the chest radiograph. Likewise, in children, those children with persistent fever and are having cough greater than 2 weeks, showing loss of weight or no weight gain, and a contact with pulmonary TB cases need testing. As far as screening is concerned, screening is done with in people living with HIV, in the malnourished, diabetics, cancer patients, those on immunosuppressant therapy or on maintenance steroid therapy. It is also done in instances where there is an enhanced chance of finding tuberculosis, and these include healthcare workers, prisoners, slum dwellers, and certain occupational groups like miners. The second standard deals with diagnostic technology. You would have been appraised of it in the previous modules. I will just mention them once again. The prime diagnostic technology involves the microbiological confirmation on sputum of tuberculosis, for which a quality assured sputum test should be done in all presumptive tuberculosis cases. Chest X-ray is used as a screening tool to increase the diagnostic algorithm sensitivity. Tuberculin skin test and the interferon gamma release assays are not recommended for diagnosis of active tuberculosis. However, a standardized tuberculin skin test in children can be used as a complementary test in diagnosis. A lately available test is the CB-NAT, that is the cartridge based nucleic acid amplification test, which is the preferred first diagnostic test in children and in people living with HIV. Here I would like to emphasize one fact, that serological tests are not recommended for diagnosis and are in fact banned by the Government of India. In the testing for extrapulmonary tuberculosis, all patients having presumptive extrapulmonary tuberculosis, we need to take appropriate specimens from the involved sites, and these specimens are examined by microscopy. Culture is performed on them, as is drug sensitivity testing, CB-NAT, and histopathology. The fourth standard deals with the diagnosis of HIV co-infection in TB patients as well as of drug resistant tuberculosis. Now all persons diagnosed with TB patients should be offered HIV counseling, for the simple reason that tuberculosis happens to be the most common opportunistic infection in HIV infected individuals. The diagnosis of MDR TB. So for the diagnosis of MDR TB, a prompt and appropriate evaluation of the patients with presumptive MDR should be done, and this involves basically a rapid molecular DST or a liquid or solid culture DST for rifampicin and INH resistance. And where possible, DST has to be done for all diagnosed TB patients prior to start of therapy. XDR TB diagnosis: on the detection of rifampicin resistance along with INH resistance or alone, DST for second line drugs using RNTCP approved methods are done wherever it is available. Standard 5 defines the category of probable tuberculosis. Presumptive tuberculosis patients without microbiological confirmation but with strong clinical or other evidence are considered as probable tuberculosis. Here we should try to obtain culture on an appropriate specimen when they are found to be negative on a molecular test. Standard 6 deals with pediatric tuberculosis. In the diagnosis of pediatric TB, a quality assured diagnostic test, preferably CB-NAT, spear microscopy or culture in respiratory specimens, is done in presumptive pediatric tuberculosis. In the instance of probable pediatric TB, the situation arises when the microbiological results are either negative or unavailable, and where abnormalities consistent with TB are seen on radiography, a history of exposure to pulmonary tuberculosis case is present, or there is evidence of TB infection in the form of a positive tuberculin skin test, and clinical findings are present which suggest tuberculosis. Pediatric extrapulmonary tuberculosis, like in adult extrapulmonary tuberculosis, we need an appropriate specimen from the presumed site of involvement for examination by a rapid molecular test, by microscopy, culture, DST and histopathological examination. Standard 7 deals with treatment with the first line regimen. Here again you would have been well acquainted with the previous module, which would have told you about treatment in detail. So, I will just go through it in a rapid manner. The treatment of new TB patients, you all know, consists of an initial phase of 2 months with 4 drugs and a continuation phase with 3 drugs given for a period of 4 months. Extension of the continuation phase is extended in the case of bone and joint TB, spinal TB and neurological TB. The extension could be by 3 to 6 months. Drug dosages are usually body weight based, and this is based on weight bands. Bioavailability of these drugs have to be ensured, and the frequency of administration is daily. Fixed drug formulations are now available, and these are a combination of either 4 drugs, 3 drugs or 2 drugs, and these are now recommended for use in the treatment of tuberculosis patients. Now, in the instance of previously treated TB patients, retreatment regimen introduces streptomycin for the first 2 months, and subsequently we have another 5 months of treatment, so a total duration of 8 months of treatment. Now, in the monitoring of treatment responses, this is done by a follow-up sputum microscopy, where in both new and retreatment PTB, one specimen is taken at completion of intensive phase and one at the end of treatment phase. Extension of the intensive phase is not recommended, and where there is culture positivity, we offer DST for INH and rifampicin resistance, and where such is detected, you also do DST for ofloxacin and kanamycin resistance. Now, the response to treatment in extrapulmonary TB is primarily clinical, with support from radiological and other investigations. Likewise, the response to treatment in children is assessed clinically, radiologically and with other relevant investigations. Long term follow up is advocated in the form of clinical and sputum examination, which is done at 6 months and 12 months following treatment. Now, standard 9 deals with the management of drug resistant tuberculosis. Treatment of MDR and XDR TB. So, this is primarily done after confirmation by a quality assured test, and the treatment is carried out with quality assured anti-TB drugs. The model of care is primarily ambulatory, and a short initial hospitalization period is done if it is felt necessary. The regimen for MDR TB uses at least 4 drugs, that are second line drugs, to which the organisms are susceptible or presumed to be susceptible, and at least one later generation fluoroquinolone and an aminoglycoside are added to the regimen. The regimen for MDR TB, where there is ofloxacin or kanamycin resistance when detected early, the regimen has to be modified during the early intensive phase, preferably not later than 4 to 6 weeks. Every patient should be evaluated for surgery at initiation of treatment and during follow up, and the treatment duration for MDR TB is at least 24 months, with the intensive phase being of 6 to 9 months. Specialist consultation is done wherever it is possible, and patient adherence to the treatment is necessary, more so as the duration of treatment is long. Sample follow up of culture is done as a form of monitoring of patients during treatment, and if the sputum culture is positive at 6 months of later, a second line DST is performed. Now, the regimen for MDR TB patients with ofloxacin and kanamycin resistance, which is detected later, here the regimen for XDR TB is used, where second line drugs including group 5 drugs are added, to which the organisms are either known to be susceptible or presumed to be susceptible. With this, we come to the end of session 1 of this topic. Thank you for your attention.